Hello, everyone. Welcome to the Preemie Health Talks. I'm Fabiana Baquin, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, GLANCE, the Global Alliance of Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For this Preemie Health Talks, we brought experts from all over the world and Canada, and we'll be diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience. And if you have any comments and questions, please ask your questions on the comments below, on your perspectives and your stories. We'd love to hear from you. And today you have 3 presentations, one with Dr. Esther Rai on the importance of breast milk, followed by Karen Lasby talking about feeding after discharge, and also Dr. Takeshi Arimitsu on the chances and challenges of tiny babies. And for our first presentation, I have here with me, joining live from Hamilton, Ontario, Dr. Esther Rai. She's going to talk about the liquid gold, the importance of breast milk in the neonatal intensive care unit. We'll discuss the importance of breast milk in the NICU, explaining the benefits of breast milk, and talk about strategies to improve mother's milk supply. We also talk about the use of donor breast milk and the different fortifiers that are added to breast milk to provide appropriate nutrition and achieve adequate growth for preterm babies. Dr. Esther Rai is an assistant professor in the Department of Pediatrics, Division of Neonatology at McMaster University in Hamilton, Ontario. Dr. Rai's academic interest lies in quality improvement in neonatal care, with a focus in QI related to neonatal growth and nutrition, as well as neonatal outreach education and nosocomial infection prevention. She has implemented numerous evidence-based guidelines and chairs several quality improvement committees, including the Neonatal Nutrition Committee. Dr. Rai is the site investigator for EPIC, Evidence-Based Practice for Improving Quality, which focuses on implementing evidence-based best practices in NICUs across Canada to improve quality of care and outcomes. Dr. Rai, thank you so much for joining us here today.
Good afternoon. Thank you for having me.
Dr. Rai, I know you have a presentation to share with us. I will let you share your screen. And I'm just reminding everybody watching us live from YouTube or Facebook, we have a Q&A at the end of her session, and you can send your questions and comments, and we're going to address all of them at the end. So here you go. Dr. Rai, you have the screen.
All right. You can see my presentation?
Yes.
Excellent. Okay. Thank you so much for having me, Fabiana. It's really a pleasure to be here. There's just a host of great speakers lined up for today and the rest of the week. So it's my pleasure to start this week off. And I'm really going to talk about, maybe just lay some groundwork, kind of the basics around the importance of breast milk in the NICU and why we refer to it as liquid gold. There we go. So we're going to go through a few different topics. So first, I'm going to talk about why breast milk is so important. We're going to talk a little bit about donor breast milk, the similarities and differences in that. And then we're going to get into some strategies to really improve mom's milk supply. And then lastly, we're going to finish off by talking about the different fortifiers and why we need to fortify human milk. So what is in breast milk? So breast milk contains macronutrients. So those are fat, protein, and carbohydrates. It contains mineral and vitamins, and particularly calcium and phosphorus, which are really important in developing your baby's bones. But what makes it so special is really the bioactive component. So the immunoprotective factors that include antibodies, macrophages, lactoferrin, and all of these play an important role in protecting your babies from infections, and it supports the development of the different organ systems. It also contains growth factors that stimulate the maturation of the intestines, and it improves the ability to digest and then absorb the nutrients that the babies take in. And then lastly, it contains healthy bacteria, such as lactobacillus, which are transferred from mom's milk into the baby through breast milk. And we're going to talk a little bit more about bacteria. So the gut microbiome, it really has an extensive physiologic influence on multiple organ systems. So their development, the maturation, and the function of the different organ systems in the baby's body. So not only does it interact or does it work to lay down your baby's foundation for their immune system, but it also interacts with the baby's lungs and the baby's brain, and it impacts the development and the maturation of those organ systems as well. So there's different factors that impact your baby's microbiome, and your microbiome is really established in the first 1,000 days of life, and it's affected by, like I said, maternal factors such as stress or infection and obesity that have an impact on the bacteria that end up living in your baby's intestines. And then there is baby factors as well. So baby's a mode of delivery, so whether the baby was delivered via vaginal delivery or a C-section, whether the baby required antibiotics for a period of time after delivery, and then importantly, what the baby eats. So whether the baby receives breast milk or whether the baby receives formula. So just to describe this in a little bit more detail here in this little table, you can see that in term neonates, baby's microbiome is mostly consists of healthy bacteria, lactobacillus and bifidobacterium. Preterm babies have different bacteria listed there, and I won't go through them, but you can tell that they are different. And breastfed babies also have that majority of lactobacillus and bifidobacterium that live in their gut. Again, those are the healthy bacteria. Whereas formula-fed bacteria babies have a different microbiome made up of different bacteria. Vaginally delivered babies tend to have a predominance of lactobacillus, again, that good bacteria living in their gut. And then C-section babies, again, they have a different makeup of their microbiome. So the intake of breast milk really sets the stage for the development of your baby's microbiome. Because it's been demonstrated in multiple trials and studies that a healthy microbiome that's made up mostly of lactobacillus and bifidobacterium can be supplemented through probiotic supplementations, it reduces the risk of necrotizing enterocolitis, death, and other important outcomes in the intensive care unit. And so most Canadian centers now supplement with probiotics, mostly lactobacillus and bifidobacterium, or a combination of those two bacteria. So just to go back a little bit to the composition of mother's breast milk itself, the composition is really highly variable and it's dynamic. So where formula products have a really consistent composition, breast milk varies in the composition, and it's really just nature's way of helping mom provide exactly what the baby needs during the different stages after birth and as her baby grows and develops. So milk of moms who deliver prematurely have a higher content of protein and fat than the milk of moms who deliver at term. The protein content is initially high, and then it decreases as weeks of lactation go by. While fat content, it slightly increases over the course of weeks. Even so, there's differences between the foremilk and hind milk in moms as well. So the milk that comes out first is called the foremilk, and the milk that's pumped near the end of a pump is called the hind milk, and that really has a higher fat content. So even within the same sample, there's variation in the amount of breast milk. just to go back up here for a second, there's also differences depending on, like I said, when a baby is born prematurely, that milk tends to have higher protein content and fat content, and that's really mother's nature's way of trying to compensate for the premature birth and trying to provide the higher nutrient requirements for mom's baby. Initially, after the baby is first born, mom's milk consists it's called colostrum in the first day or even 2 days of life, where you can see the picture on the left here, that yellowish milk. And that's really high in all of those important immune protective factors, antibodies and things, as well as high in protein. And then as mom transitions to more mature milk, that protein content ends up gradually decreasing over time. So now that we've talked about the differences in the breast milk, I'm going to talk a little bit about what the benefits of human milk are. So compared with formula, human milk reduce many of the fear complications of prematurity. So we see lower rates of infection, lower rates of necrotizing enterocolitis, lower rates of retinopathy of prematurity, bronchopulmonary dysplasia, and we see fewer rates of rehospitalizations in the first year of life as well. And we see improved neurodevelopmental outcomes when we see these beautiful babies back, at that check-in time around 24 months. Long-term benefits of human milk also exist, so it's not just short-term, but we see benefits even into adolescence and beyond. So children who, or babies who were mostly breastfed, they tend to have lower rates of metabolic syndrome when they are in adolescence. They tend to have lower blood pressures. They tend to have lower low-density lipoprotein or cholesterol levels, and they have less insulin resistance. And studies over time, I mean, there's been so many studies and randomized controlled trials that have looked at the impact of breast milk on outcomes, and it's really become clear that there's a dose-response relationship. So even small amounts of breast milk provide benefits, and the more of it you're able to provide for your baby, the higher the impact of the breast milk is, and the more beneficial or the better the outcomes are. So what about donor milk? So donor milk is pasteurized to inactivate viral and bacterial agents. And in doing so, of course, also the good bacteria are killed. And the second important piece, or the second important impact of pasteurization on milk is that it reduces the important bioactive components that we talked about earlier. So they have lower antibody content and growth factors. Donor milk also has a lower protein content, and it's partially due to the pasteurization process, but it's also because milk that's donated to milk banks tends to be donated by either by term moms. So if you remember earlier, I was talking about the variation in protein content of breast milk, and as moms go through their lactation journey, the protein content gradually decreases. So by the time moms have enough milk to start donating to milk banks, they tend to be at a later stage. And so there's less protein in that donated milk. So that's the second reason why, generally speaking, donor milk has a lower protein content. And then lastly, donor milk is lower in fat content, and that's really due to the freeze-thaw cycles that happen as we process donor milk, and it's changed from different containers where the fat tends to stick to the plastic containers and therefore is essentially taken out of the milk. So does donor milk have the same beneficial effects? And most of this information on these slides comes from a really great review article by Paula Meyer's group about that talks about donor milk. And when we compare donor milk strictly to babies who receive formula or mom's own milk, it is clear that donor milk fed babies, they simply don't grow as well, and they tend to require more fortification, and that's likely secondary to that lower protein content. The benefits of donor milk are still present, perhaps to a lesser degree, and we can definitely see when we compare strictly formula-fed babies to donor milk-fed babies, there is a decreased risk of necrotizing enterocolitis. And Dr. Meyer talks about how it's likely not so much the makeup of the donor milk itself or the properties of the donor milk itself, but rather just the avoidance of formula that leads to these reductions of adverse outcomes. So now we've talked a lot about breast milk and why it's so important. And I want to kind of shift our attention now to how can we optimize mom's own milk supply. And really the key here is early discussion about mom's intent to breastfeed or to provide her own milk. And we want to obviously do that in a very non-judgmental approach, especially when moms initially express their wishes to formula feed the baby. And in those circumstances, it really is up to us as healthcare providers to explore some barriers and or fears about her hesitation to initiate or provide her own breast milk. So some moms might find that they don't want to provide breast milk because they're taking medications and they're worried about that medication being passed on through her breast milk and to the baby and having an impact on the baby in a negative way. And so just talking through some of those hesitations oftentimes will provide mom with enough information to make an informed consent to and decide to provide her own milk. Similarly, some moms might think that it's going to hurt. So there's counseling and education that we can do and making sure that we provide her with all of the information that's required so that she can make an informed consent about providing her own milk. And 99% of the time, those conversations are very helpful and we're able to get mom on the same page as us. So as we have these discussions, it's really important to put an emphasis on what mom can do to help her baby avoid the complications that we often encounter in prematurity and to stay as healthy as possible through the NICU course and then obviously beyond. And really, this is a way for her to gain some control back over a situation where she's probably felt like she's lost complete control over the situation, given that she's just had a premature baby. She's going through an extremely stressful time in her life. And so this really gives back that sense of control a little bit. As I mentioned, of course, we have to explain that breast milk reduces the chances of infections and other complications of prematurity. And this is her way of being able to help her baby with that. It's really important to set very clear expectations of how we can optimize mom's milk supply. And the key here is really being consistent in messaging, which is really crucial. Sometimes we still occasionally hear, for example, if a mom's delivered at 9 p.m. at night, we touch base with mom first thing in the morning and ask her, have you been able to get any milk yet? And the response occasionally still is, I was told just to rest overnight. I had a rough delivery. And so we've really missed an opportunity in those circumstances where mom could have started pumping early, and that unfortunately was missed. So consistent messaging and knowledge of our frontline healthcare staff is really, really important so that we're all on the same page of what needs to happen in order for that milk supply to be optimal. So key things here are the early initiation. And really, when I say early, I mean ideally within the first hour. Studies have shown that for moms who initiate in that first hour, their milk supply is significantly higher at 7 days than moms who started after that first hour. And that effect is really sustained to 6 weeks postpartum and beyond. Secondly, the frequency is very important. So we want mom to pump at least every 2 to 3 hours for 15 minutes, a minimum of 8 times a day. She really shouldn't go more than ideally 4 hours overnight without pumping. And we want to make sure that she's using, ideally, not hand expression, but a hospital-grade double pump to really get the most out of that. So the second important piece is to have support in place for her. So early and continued lactation consultant support is really important. Lactation consultants are able to make sure that moms have the right supplies, the labels, the pump supplies, the shields, all of those things. And they're able to provide emotional support, of course, because this is a scary time for her. And providing that emotional piece that she has one touch-based person that she can go to is really, really important and helpful. Really, as I mentioned, the expectations are really important to lay out and explaining to mom that, you might not get anything the first few times that you pump. even if you see a few drops, it might not seem like much, but it is a lot, and we do want those few drops even brought over to the NICU, and ideally you or the nurse will put that milk into your baby's mouth because it contains a lot of important protective factors like we talked about earlier. Being able to set mom up with some targets is really important too, just so she herself can track how she's doing as the days progress in the first 2 weeks. And it also allows us to kind of track how she's doing. Are there any problems, so that we can identify those early, and the lactation consultant is able to make changes to her pumping plan or medications if need be. We know that the first 2 weeks of milk expression are critically important in establishing and then maintaining that milk supply. So this is why we're so focused on that right from the get-go, as stressful as that time may be. It is a very heavy workload to pump, and you feel like all you do is eat, pump, sleep, and then pump again. So partner and support person involvement is really important and can alleviate some of those stresses from mom through just even helping with the cleaning of the kits after mom is done pumping. So that's important if a person is available to have them involved and really doing hands-on things to help mom out. I just want to spend a little bit of time talking about, how do we cope when, or what do we say or shouldn't say when milk supply isn't quite enough? I mean, there's circumstances where moms, they do everything right. They follow our advice, but they simply don't quite get enough milk to support their babies. And sometimes that's secondary to, oftentimes actually, it's because there's risk factors involved that place her at risk for not being able to provide enough milk. So perhaps she has a history of infertility, perhaps she's overweight or obese, perhaps she had pregnancy-induced hypertension, she may have had excessive blood loss at the time of delivery, she may have delivered via C-section, in which cases we know milk supply may not be as good as when a mom delivers vaginally. So when we're speaking to healthcare providers, for us on rounds, it's important to say, we avoid saying things like, well, there isn't enough milk, we're using donor milk, because if mom's at bedside and she's part of those conversations, it might sound like a failure, or she might feel that way. And so just being aware of how we talk about that on rounds is important from a healthcare provider perspective. So if breast milk is liquid gold, then why do we add a fortifier? So we're going to switch gears a little bit and talk about fortification. So premature babies, they have a greater nutritional intake needs in the neonatal period than any other time in their life. So one of the main reason, there's two reasons. One is, but the most important one is probably to support appropriate growth. So premature babies, they have much faster growth rates than babies who are born at term. So when you look at this little table here, you can see that babies around 23 to 27 weeks of gestational age in utero, so as fetuses, gain about 21 grams per kilo per day. That drops to almost half by the time they're 37 weeks. So you can imagine how fast they grow, and and in order to support that growth, how much nutritional support they actually need. On top of that, they're not inside of their mom's tummies anymore, and so they may have medical conditions that increase that metabolic demand even further. And then lastly, they have immaturity of the intestines, so they don't quite have the same ability to digest and absorb nutrients than a term baby might. So all of those things combined lead to a higher need for nutritional intake, and we do that through adding fortification. The second important part, aside from growth, is the need for minerals. So calcium and phosphorus are incredibly important, and they tend to be laid down or built up in babies in that third trimester. So it's really important that we supplement with that in order for their skeletal system or their bones to grow nice and strong. So Fortifier, most commonly used fortifiers are multi-nutrient fortifiers, and they contain, like I said, varying amounts of protein, energy, minerals, trace elements, vitamins, and electrolytes. But there's also single macronutrient fortifiers available. So for example, babies who receive mostly donor milk, that is a relatively low in protein content, we can add just simple protein fortifier to those donor milk feeds if need be. And then the types of fortifiers that are available, the protein can either come from a bovine source or human source. The bovine source or cow source, it can either come as a powder fortifier, which essentially means that it comes from intact bovine protein, or contains intact bovine protein, I should say. And then there's also a liquid fortifier that's available, which contains extensively hydrolyzed bovine protein. And so that essentially means that the protein is broken down into smaller pieces. There's also a fortifier available that is obtained from donor milk. So the bovine powder has very little displacement of mother's own milk. So that's definitely a pro. The osmolality, or the concentration of the particles in the breast milk, is not a concern. So it's just raises the osmolality by a little bit compared to mom's breast milk without any fortification. The cons are that, it does contain intact bovine protein, and the powder form is not sterile. I'm not so sure how big of a concern that is, given that mom's milk is also not sterile, but it is not sterile. The liquid fortifier, which is now more frequently used, I would say, it's extensively hydrolyzed bovine protein. And it's slightly higher in protein content than the powder fortifier, so that's another plus. And it is sterile. Some cons that we have to consider are that it does displace mother's own milk slightly by about 17%. And it is fairly high in osmolality, meaning we can't really add very much other supplements to safely stay within the osmolality that's recommended for enteral feeding. And then probably one of the most hotly debated topics right now in neonatology is human milk-derived fortifier. And this is donor milk that's essentially comes from a donor milk product that's pasteurized after rigorous testing of the milk, and it's tested for bacteria, viruses, and illicit drugs, nicotine, all of those things, and it's even matched with a milk DNA print to make sure that the donor is that the person who's donating the milk is actually that the milk was actually received from that person. So it's a really rigorous process in terms of safety profile, and that milk, that donor milk, is then pasteurized using the VAT pasteurization process. This is a slightly different process than what we use here in Canada at the milk banks, and the VAT pasteurization process does reduce the lactoferrin content a bit more than the Holder pasteurization process that we use here in Canada. So that's a con, I would say. The pasteurized milk is then concentrated to various caloric densities, and then the vitamins and minerals are added. Of course, the big pro of this is that it's a human protein source. The osmolality is really not a concern, and this product is also sterile. Definitely a con is that there's a high displacement of mother's own milk. So perhaps less of a concern in babies who receive mostly donor milk, but when we're talking about babies whose moms have an excellent milk supply, we are now displacing their milk with 20 to 40% of a donor or foreign product, really. And the second big con is that it is really, really expensive. So the million-dollar question is then, is one better than another? I know this has been previously discussed in this forum, so I won't go into the details about the literature itself, but I will say that expert bodies do not currently recommend one fortifier over another. There is emerging evidence to suggest that human milk-derived fortifier may reduce necrotizing enterocolitis, retinopathy of prematurity, and possibly late-onset sepsis. And there was a study, a meta-analysis that was done last year by Lucas et al. And he combined 3 studies and that contained roughly about 450 babies. And they did find a statistically significant reduction in NEC, ROP, and feeding intolerance. So I would say there's definitely emerging evidence for this, but so far we don't have large numbers yet. And I think some would argue that the cost at this point is quite high. And so we have to weigh the risks and benefits and take the literature all into consideration to make these decisions. And so this is a really hot topic right now. I'm going to shift away to the last part of my talk here to talk a little bit about how do we determine how many nutrients we should add to milk. And so we're going to talk about standard versus individualized fortification. So standard fortification is a process by which we add a standard amount of fortification to mom's milk. And really that's based on the average content of human milk that's been determined by, combining a lot of samples together and then calculating how much protein and how much fat is in that average sample. And then based on that, we're adding a standard amount of fortification to mom's milk. That being said, this is of course not individualized. And as I talked about earlier, each mom's milk has a different makeup and a different composition. So some babies, by using this method, some babies may get too much and some babies may get too little because we're adding the same to each mom's milk. It is still most commonly used, and it's very practical. But like I said, it doesn't consider the variations in milk composition between moms and even within mom. So is there a better way where we can use an individualized approach for each baby and fortify their feeds to what they might need? There's two ways or two approaches to this. The first one is an adjustable fortification. So essentially we're using a lab value, a blood urea nitrogen measurement twice a week. And if it falls within the target range, we assume that the baby is getting enough protein. If it's below the recommended range, then the baby may be getting too little, and so we can add more protein. And if it's above the recommended limit, then the baby may be getting too much, and we might decrease the amount of fortification that we provide. So this is quite a practical approach to it. The second way we can individualize fortification is by targeted fortification. So in this way, we would take mom's milk sample, we analyze it, and we determine how much protein, how much fat, how much carbohydrate is in the sample, and then we supplement based on that. So if mom's happens to have a low protein content in her milk, we would add additional protein up to the recommended dose. This is, of course, labor intensive and it requires breast milk analyzers, but this is certainly also a hot topic of discussion in the neonatal nutrition world at the moment. So take-home messages from my talk. So mother's own milk is a crucial medicine provided to preterm babies as it improves survival and it reduces complications associated with prematurity. Donor milk should be offered if mom's milk is not available. Ensure timely lactation support is in place and set clear expectations around all aspects related to pumping to optimize mother's own milk supply. And fortification of breast milk is necessary to provide adequate nutrition to support organ growth and development. So Fabiana, I'm more than happy to answer any questions.
Thank you so much, Dr. Rai, for your absolutely incredible presentation. I want to thank everyone participating. We have people from Kashmir, we have people from Zimbabwe. Actually, Francis from Zimbabwe said, what an educative discussion. Thank you, Francis, for joining us. I love having this international audience. It's really great to see so many people from around the world joining us. Dr. Rai, let's talk about fortification. That was your last in your presentation. So how soon do we start fortifying baby's milk?
That's a great question. Baby. Yeah, so I would say the sooner the better, of course. We want to try and supply the optimal nutrients as soon as possible. And the best way to do that, of course, is enterally, so through the intestines rather than through an IV or through TPN. So generally speaking, we fortify around when a baby reaches about 80 to 100 mils per kilo per day of mom's breast milk. So once a baby can tolerate that, we try adding about half a dose of the fortification for about 48 hours and make sure the baby tolerates that. And then 48 hours later, we add that second half to it so that we're then fully fortified. You know, the human milk fortifier, the company that makes that, they recommend fortification even earlier. And so that is another actually pro of that product, where the fortification can start as early as 40 to 60 mils per kilo per day. So yeah, right around that time.
That is incredible. So I think my question, a lot of parents always bring up those questions. Once we start fortifying the breast milk, they notice the baby start having a little bit of reflux. Is this a common thing to happen with those babies?
It is very common, yes. So, you know, it's hard to say, you know, it does tend to happen around the time of fortification, but oftentimes I will say, babies who end up having persistent feeding intolerance, they had it even before they were fortified, and they continue to have it after they're fortified. And yeah, it is quite common. Like I said, it's the GI tract is very immature still, and so it's not supposed to see nutrition yet. It's not supposed to be all of a sudden digesting things and starting to absorb them. So it takes a bit of time as the GI system adapts to that, and so we call that feeding intolerance. And so sometimes it's you know, manifests in the form of having some spit ups. Sometimes the baby is quote unquote gassy. So there's different ways in which that can manifest itself.
Okay, so when baby's getting closer to going home, and obviously you want the babies on a full feeds and, you know, all the good stuff to make sure the baby is growing and is healthy going home, why some babies still have to have fortification on the transition into home? And I'm sure Karen Lasby, our next speaker, is going to address that, but I want to thank you for the last few weeks of the NICU leading to going home.
It's all about growth. So the brain development, and I was going to add it to my slides, but I thought it was going to be too long. But the thing that we focus on the most is really providing adequate nutrition to make babies grow the way they would have if they had still been in their mommy's tummy. So if babies are falling behind, despite what we do in the NICU, it's possible that they need to stay on those extra nutrients to try and at least maintain or even do some catch-up growth, you know, after they go home. And so that's not uncommon.
Okay, so we have another great question here from Mena. When would you add the probiotics, and what complications might occur?
Oh, that's a great question. So I am in Canada, where we have very strict health regulations around the probiotic products. So it's very rigorous around, you know, safety of those products. So complications, I guess I'm starting by the end of that, answering the last part of that question. The complications theoretically are that there may be contamination of those products, and babies may get infections from them. There is a few case reports out there in the literature when you look. However, it's extremely, extremely rare, and by far the benefits of probiotics outweigh the risks of that. Like I said, in Canada, where we have very strict regulations around those products, I have not come across a case report in Canada because of that. We start probiotics, like I said, the microbiome starts to develop right after birth. And so we start probiotics as soon as the baby is ready to have its first feed. So it started with the first feeding.
Wow, that's very early.
Yeah, it's very early, and we continue them on even after babies are transferred to a level 2 unit, or even after they go home. Parents oftentimes will say, "Hey, where can I get this?" And you can actually just buy it at the pharmacy, at the grocery store.
Dr. Rai, one question that I have in relations to oral immunotherapy, because after your Karen Lasby session today, I talked to a doctor from Japan who saved the smallest baby, 268 grams, and he started doing OIT on day 1 of life. So what is your take on that? And is this a common practice in Canada now?
Absolutely. So OIT is incredibly important. So this is where we take that colostrum that's really, really high in the immunoprotective components that we want to coat the baby's intestinal tract with. Sorry, we have a visitor in the background. So we coat the baby's intestines with that. So that colostrum is incredibly important. The immunoprotective factors are absorbed in the baby's mouth. So as soon as we have any drops from mom, we apply that into the baby's mouth. Ideally, the mom does it herself if she's able to come and visit her baby already. But as soon as we have some, the support person or partner comes over and we put it right into the baby's mouth right as soon as possible.
Okay, let's talk about colostrum, because, we always know this is the liquid gold, and this is so important for babies. Talk a little bit about colostrum to just remind everyone how important
So the colostrum is the very first milk that's produced by mom. It's that yellowy colored that I showed you in one of the pictures, and it's kind of thick and mucousy, and really it is just so full of those antibodies and immunoprotective and growth factors that are really so important to first get into the baby to start, maturing or coating really the gastrointestinal tract of the baby. So all of those important nutrients are absorbed, right? Like as soon as you put it into the baby's mouth. So the colostrum, although it looks like, oh, I've only gotten 1 or 2 drops of breast milk, we want moms to bring it over. It's that important. So yeah, I hope I've emphasized that enough. So before that milk transitions, any drop of colostrum we can get our hands on, we want to take it.
So we have another question from our live audience. Nina asked, are anti-reflux meds successful in reducing reflux in preemies? Thank you, Nina, for your question.
Great question. And we get this a lot, right? It goes hand in hand with that question about, oh shoot, I'm losing my train of thought. Feeding intolerance. Yes, that's what it was. So I think, here's the thing. Most babies have some form of reflux. It's part of their immaturity of their GI system. That sphincter that keeps all of their food into their tummy is also not super tight yet, that big muscle. And so it's easy for milk to come and reflux back up. Sometimes it can be significant enough where babies are not retaining enough of their milk. And so in those instances where we see poor growth secondary to reflux, or we are attributing it to reflux, we may try anti-reflux medications. But in general, if a baby is growing well and does not appear to be uncomfortable, or it doesn't impair oral feeding once they get a little bit bigger and they're able to start working on oral feeding, we tend to not treat with anti-reflux medications because there's always side effects to reflux medications.
Okay, so we have another question here from Nina, but I believe a pediatrician can guide her on that direction. But my 32-week preemie is being prescribed anti-reflux medication as the reflux is believed to be causing O2 desaturation. After we finish the 8-week treatment, should the episode stop?
So reflux is believed to be caused by... After we finish the 8-week treatment, should the episode stop? So, I mean, usually speaking, maybe I should just back up. So anti-reflux medications, depending on what is being prescribed. So there's really 2 types. One is what we call a pro-motility agent that essentially starts to move things down in the GI tract, so less of it can come up. The second type of medication is an antacid. So it reduces the acidity of the stomach contents so that it causes less painful sensation in the baby's esophagus. So, like I said, so if you are using the one that moves things along, you should see improvement in your oxygen saturations, right? Because less is coming up, causing those desaturations. If she's been prescribed an antacid, the same amount of milk will still come up. It might be less acidic and less irritating, but it shouldn't actually have an impact on your O2 saturation. So it really depends on which medication was prescribed. And if it's a combination of things, then you should see a benefit. But usually we tend to try a baby on it for a couple of weeks before we can say, yes, it worked, no, it didn't work. Absolutely. So that 2-week mark is sort of where you can make a determination.
Okay, Dr. Rai, our time is almost up, but I have one last question for you. In early pumping, we know how important it is, and a lot of parents have expressed with us their concern. They are not being very supported in pumping at this time. With COVID, there is less support for pumping and breastfeeding. So I think I would like to hear from you how important it is to early pumping, as you mentioned before, and the support during the NICU stay.
Yeah, early pumping is absolutely, it is the most important thing. Like I said, it's very clear from the evidence from the literature that early pumping, meaning less than an hour even, the earlier the better. And that really predicts the milk supply that the mom will have throughout her lactation journey. So that might be a few months, or it might be 6 months, or even up to a year. So those first 2 weeks are absolutely critical. The earlier you start, the better. It's difficult with COVID. I'm very grateful that in our center, our lactation consultants are there. They are essential. They are able to provide the support that they were before COVID. And I think during this time, healthcare professionals in centers where that might not be the case, it's really upon us to touch base and do some of that counseling with mom. And I think nursing support is really important from that aspect as well.
Absolutely. Dr. Rai, thanks so much for joining us here today. It was a great presentation. I'm very grateful that you took the time to share your knowledge with us today.
Oh, thank you, Fabiana. Looking forward to the next few talks.
Yeah, thank you. And thank you all of you for joining us here today live on Facebook and YouTube channel. We'll be back in just a few minutes with Karen Lasby, talking about feeding after discharge. And then we're going to have Dr. Takeshi Arimitsu talk about the chances and challenges in tiny babies. I want to thank our sponsors, Medela, Water Wipes, and Prolacta for their ongoing support. And CPBF is a registered charity, and 100% of all donations received this week will go to our support programs for families. To donate, please go to the Canadian Preemie.org and stay tuned. You'll be back in just a few minutes. Thank you. Hello, everyone. Welcome to the Preemie Health Talks. If this is your second session of the day, welcome back. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANCE, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For these Preemie Health Talks, we brought health experts from around the world and from all over Canada. We'll be diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. And I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience. And please interact with us. Send your comments or questions on the comment section below. And today we're going to have, after this presentation, Dr. Takeshi Arimitsu talk about chances and challenge of tiny babies. And right now I have here with me, joining me live from Calgary, Karen Lasby. She's going to talk about feeding concerns after the NICU discharge. So feeding concerns are very common after babies leave the NICU. In this presentation, we explore signs of feeding trouble that commonly occur in early weeks after NICU discharge, and we'll describe easy strategies for parents to implement at home. Karen is a nurse in her 4-year career, has helped her become an expert in the support of premature babies and their families after the NICU discharge. Karen has made presentations locally, nationally, and internationally, and she has written and taught online courses to educate nurses about how to care for babies in the NICU. She has also been a research co-investigator and has published articles related to premature babies. And she served on the executive boards of the Canadian and international associations for neonatal nurses. Karen and her colleague, Tammy Sherrill, co-authored an essential parent book for parents of premature babies titled Preemie Care, A Guide to Navigate the First Year with Your Premature Baby. Karen, thank you so much for joining us here today. Always a pleasure to have you and to talk to you and have your knowledge shared with our families. I'm very grateful that you took the time to join us today.
Oh, I very much look forward to these talks. So, yes, let's get started, shall we?
Yes, you can share your screen, Karen. And for all of you watching us from home, you can please send your comments and questions, and Karen will answer them after her presentation. Okay, here you go. Karen, you can go on a slideshow now.
You're good?
No. Or
No.
You see all your slides. Are you in full screen?
I'm in full screen.
Okay, try to move one slide, see what happens. Sometimes works. No. Okay, let me try to share my screen to see if it works a little better. So you can have your full slides here. Let's see.
Okay.
You know, technology happens. Okay, here you go, Karen. It's all yours. Just let me know when I need to move your slides.
You can actually move to the next slide. I mean, feeding problems are the #1 concern of parents after they take their baby home from the NICU. It is the meat and potatoes of work in the community with premature babies. And I want to just start with an example. You know, parents, you've spent days and weeks and months in the NICU. Your baby might have been a 23-weeker or a 36-weeker, and you're taking your baby home now. And the first couple days, you've got your NICU plan, you're all psyched up, you've been practicing in the NICU, and a day, 2, 3 days later, suddenly breastfeeding's not going well. Now your baby is spilling, now your baby is coughing, choking, maybe your baby's falling asleep during feeds, not taking enough, so is the bottle wrong? So you go out and you buy a dozen different kinds of bottles on the market, you try every one of them, and nothing seems to work. Feedings are not fun for anyone. They're not fun for your baby. They're not fun for the parents. No one's enjoying it. It's not supposed to be a pleasurable thing, and no one's enjoying themselves. Everyone's stressed. And when we look at these scenarios like this, we know through the research, we know that feeding stress impacts the baby's long-term relationship with food. So the baby's going, I don't like this, and they start to rebel. And also feedings impact the family. They impact the mother's confidence, the father's confidence, the relationship between family members, the mood in the house. Oh no, it's feeding time. Oh no, look out. Here we're stressed again. You can go to the next slide. So we want to avoid that, right? And there's things that parents can do before they even whisk off to see their healthcare provider, because goodness knows, and certainly in these times of COVID, the more you can fix at home, the better. So that's starting off right. We know that that NICU discharge plan is really only good for a couple days. Your baby changes. Your baby wants more. And if you have one of those discharge plans that says, feed your baby every 60 mils every 3 hours, that's not going to work very long. Your baby is going to say that is underfeeding me now and I demand more. So the plan needs to change. So we know that when babies go home, they're not efficient, they're not proficient, they're not expert at feeding, they're good enough to go home. And as they age at home, as they get more and more mature, things change. Their mouth gets stronger, they can suck stronger, and now they're drawing more milk in, whether that's from breast or bottle. They can get them into trouble when maybe they weren't in the NICU. So feedings need to be pleasant. So we start off saying, no big changes. Don't say, I'm going to change the next 6 things, because then when you're evaluating it, you don't know what's worked and what's not. One change at a time. Say, today I'm going to try this, or this half day I'm going to try this certain strategy, and then let's see how it goes. And then unfortunately, your baby's going to change tomorrow, and you're going to have to kind of start from square one, because they're a moving target, these babies. They like to keep us on our toes. No coaxing, no pushing, no force feeding. We want feedings to be pleasant. We want your baby to decide when to feed and how much to feed. And one thing I suggest is that you just write things down. You know, you're used to seeing things written down in the NICU. Get a piece of paper or get an app on your phone and just start recording. How's the baby doing at the breast? How's the baby doing at the bottle? If you're tube feeding at home, keep track of all of that, because when you go see your healthcare provider, they're going to ask for details, and you're going to feel a little sleep deprived, and remembering, 4 or 5 days ago, it might be a bit of a challenge for you. So have things written down so you can just say, here, you can see for yourself. Okay, next slide. Thank you. So we've been talking a little bit about breastfeeding, the importance of early pumping. Breastfeeding, I could spend, a day talking on breastfeeding. So I'm just going to share 2 key points. So if your hope is to advance breastfeeding, number 1, make sure that your milk supply is there. That will entail pumping. That will entail moms looking after themselves. Make sure your milk supply is there. If it's not, go and see a lactation consultant or breastfeeding clinic to get that support. And then second point is going to be get the baby in the kitchen. Get the baby on the breast. So in the NICU, you may have been breastfeeding 1 or 2 times a day. Or if your baby's a very lucky baby, maybe you're breastfeeding more often in the NICU and spending more time there. But there's no perfect way to advance breastfeeding. So we recommend just getting the baby there. So let's say you're breastfeeding a couple times in the NICU, stick with that, but start adding some practice time. So just get the baby on there for a couple minutes while the bottle's warming, so that they get lots and lots of practice, so that they're, learning from 1 or 2 breastfeeds a day is really challenging. But if you're practicing most feeds, then you're going to be able to start advancing. But finally, seek guidance from your community supports. You're good. You're good. Thanks for advancing. So how do you know when feeds are going well and they're not going well? So let's start off with the not going well. The baby is restless. They're moving their arms all about. They're active. They're arching back. Their face looks stressed. They're like, this is scary. They're coughing. They're choking. They're gasping for breath. They pull off the bottle or the breast and going, I have to take that breath. They're spilling. They're noisy and sloppy when they're drinking. They don't take enough. They fall asleep in the middle of the feed. They're feeding faster than 15 minutes, so they're getting it in, 5 minutes flat, or they're taking an hour. And gosh, we certainly see that happening. And they awaken after a short sleep. So less than an hour later, they're up again going, I'm hungry. So something's going wrong here. So instead, we want to have a calm baby who has a relaxed face, who's making sounds on the while they're feeding at breast and bottle. Small little drops are okay. We want them to be full and satiated at the end of their feeding. We want them to feed in about 15 to 30 minutes, not too fast, not too slow. And we want them to sleep 1 to 3 hours. And notice it does say 1 to 3 hours. Full-term babies feed about that often. So in the NICU, your ex-prem may have been fed every 3 hours in the NICU, But what is normal is being fed every 1 to 3 hours. So if a baby wakes up after 2 hours with hunger cues, they're the boss and they get fed. Next slide. So the most common problems that I see in premature babies after NICU discharge is that they fall asleep before finishing the feed. And so the family says, well, I was supposed to give them 60 and they're falling asleep at 40. What do I do? And just click that one more time. And what happens often is parents are stressed and they're saying, oh no, in the NICU, somehow my baby was drinking 60 mils every 3 hours and now I can only get them to drink about 40. And so they're doing coaxing methods and those snowball, those end up being problematic. So we want to have really positive interactions with feeding. So we're going to try to avoid that heavy coaxing. So next slide. So first off, consider your baby's corrected age. So if you're taking home a baby who is close to your due date, that's a full-term baby, and those babies are fed every 1 to 3 hours. So it's not awful if they're waking up every 1.5 to 2 hours and saying, I want to eat. Small, frequent feeds are actually a great strategy for babies. They think, I can handle this. My tummy feels great. I got lots of nutrition. It's just a lot more work, but it is very satisfying for these babies to feed frequently. Watch those early hunger cues. At the beginning, they're very subtle and they kind of, and that's it. And they go, okay, I'll go back to sleep. But we want to act on those early cues and say, oh, are you awake? Do you want to try a little bit of breastfeeding? Do you want to try a bottle? And so catch those early cues. They will get stronger as your baby gets older. And as one mom that I spoke to not too long ago, she said, my baby is like a light switch. It's dark, asleep, and then bing, the switch goes on and my baby is gone ballistic and I need to eat now. And she says, I got to find those early cues because this is the baby's just too frantic to eat and to latch onto the breast. Wake up the body and not the mouth. So when your baby is falling asleep at the bottle, resist the temptation to move that bottle. No wiggling, jiggling, moving in and out. I know that makes the baby start sucking again, but this is not a good practice for your baby. What I would suggest instead is wake up the body. So you give them a little rub down. Say, hey, how about a little burp break? Or if you need a little cat nap, that's okay. I'll lay you down in a safe location. And then let's come on up until you cue again. So wake up the body, talk to them, sing to them, and help them arouse by themselves. Change the diaper mid-feed. I really like this strategy. Parents informed me of this strategy decades ago, and it's my go-to. If you're saying your baby falls asleep mid-feed, I suggest when your baby wakes up next, start breastfeeding or bottle feeding your baby first. Feed for about, whatever, 5 to 10, 15 minutes. Come up for a burp break. Carefully change their diaper. You don't squish them their legs over, just kind of carefully change their diaper. And now they're going to be invigorated again. And then say, okay, here's part 2. Let's finish this feed. I've already talked about burping and lying the baby down until they cue again. So again, moms will say, well, he falls asleep after 5 or 10 minutes of breastfeeding. I'm saying, okay, so let's do the diaper change midway. But then that's also, okay, that didn't work. Okay, baby's had a partial feed, burp time, holding up a little bit. Now just lay down uncovered in a safe location in your bassinet or your crib and saying, you just think about your breakfast there, and I think you'll want a little bit more. And I guarantee in about 5 or 10 minutes, that baby's going to go, wait a second, I'm not done. And we'll continue again. Maximum 30 minutes feeding time. So not including your burp time, but let's just say maximum 30 minutes of extra. Think of feeding like exercise. If you over-exercise, you overdo it, and then you're exhausted for the day. Let's say 30 minutes of active feeding time. So maybe it's 30 to 40 minutes, counting burp time, but you don't want to be spending an hour feeding your baby. And the next slide. The second most common challenge that I see, I just want to show them the golden retriever holding the bottle ever so still there. You just captured that. Okay, the second most common feeding problem that I see, particularly problematic for bottles, is we call it flooding, which means they're spilling, they're drinking too fast, they get kind of some caught in their throat, they start coughing, they might choke a little bit. So we want to see, can we do something to prevent this from happening? And certainly if you're breastfeeding, a lactation consultant will give you ideas on how to lessen that letdown. You might need a pump first or lay back so that the baby isn't rushed with that milk quite so much. But at the bottle feeding, know that, and at breastfeeding, know that suck strengthens over time. I've mentioned that earlier. And so this baby's getting stronger and stronger. And so we really want to say, it's normal to suck hard and fast on the breast. That's what brings the milk down, but it can cause trouble in the bottle. So what we recommend is making sure they're on a nice slow flow bottle. You can switch to the next slide. And just we want to make sure that we have them positioned in, I really like that side lying position, the two pictures at the bottom, so that the pillow's under the body, they're laying side lying, they're in that nice sniffing position. High cradle, that bottle can drip. You can go to that next slide. And then those bottles, oh my goodness, this is a nemesis for parents. Bottles are a common reason for feeding problems for our ex-prems. Different shapes, different flows. No flow is the same between bottles. It's a scary show out there. And so next slide. What you want to choose is a bottle where your baby can have a really nice latch. This is not a good latch. This baby is just like right on the little nub. So this is one of the reasons why I avoid wide bottles, because they often have that little narrow pointy end and the baby just latches on that. If you go to the next slide again. So instead, what we're looking for is that nice soft latch on the nipple. So there we go. So very similar on that left-hand side. You can see pink, a little bit of pink on the top and the bottom. Oh, just back up a little bit. And then with nice latch, nice relaxed face. And we don't want them on that little tip again, so on that right-hand side. Okay, next slide. So start the commercial nipple in the NICU. Oh, that's revolutionized the transition home for families. Slow flow, narrow, get it working in the NICU before you take your baby home. Warm the nipple on the bottle. It gets a little bit of pressure in the bottle. So just before you give it to your baby, unscrew the top, get it back down again so it doesn't splash all over your baby's face, not too fast. The tightness of the collar does affect how tight, how it flows. So if you want it to be really slow, you tighten it up. If you want it to back off a little bit to make it a little bit faster. A full bottle will generate more pressure and faster flow. So keep that in mind if you're filling up those bottles. Nipple integrity does change over time. So those commercial nipples that are made out of silicone, they do break down over time. So you might need to replace them. And just be careful when you go up to that faster flow nipple because it could be a big change. Okay, next slide. Just a couple more slides here. There's the bottle. Okay, next slide again. So one of the strategies that we have for babies who just like to rush on the bottle, they rush on the breast, that's great, but rushing at the bottle does not work. And so if you see your baby with these signs, they're squirming, they look worried, they're spilling, drinking very fast, then just pull the nipple out. So, you know, 1, 2, maybe 3 to 5 sucks. 1, 2, 3, and then pull that bottle straight out, rest it on your baby's lip, and then just let them swallow. They'll open their mouth again and say, okay, continue. But if, you know, until they start doing that pausing, we do that pacing for them, and it really helps slow down that feed. Okay, next slide. And so the baby is the boss. You know, our takeaway messages are we want a positive feeding experience. We want to transition to cue-based or infant-led feeding. That means different volumes, different times. That is normal. Watch your baby for hunger cues, watch them for satiation cues, keep your breast milk in, you reach out to lactation consultants and breastfeeding clinics, use your bottle feeding strategies so that we can optimize, make that feeding as pleasant as possible. And then the final slide there. Sorry, Fabiana, for making you do all that switching around there, but thank you for inviting me. Feeding is a #1 challenge, and certainly in our book, Preemie Care, we spend so much time talking about feeding, whether it's breastfeeding or bottle feeding. So she's got the website there if you want to go for more information. But feeding is the #1 concern. So I'm don't be surprised if it's top of list for you as well. But there's so many, try some of these strategies out.
Oh, Karen, thank you so much for your presentation. Yes, sorry about the slides because I'm monitoring 2 computers and comments, but always so great to have you and sharing your expertise with our families. So I guess my first question to you is, because we leave the NICU on a schedule. Baby has to feed every 3 to 4 hours and then ICU. How is that transitioning home? Like, do we switch off the schedule to go with baby cues right away, or you wait a few days, a few weeks until baby's more adjusted home?
So good question, because that comes up always. So the transition is difficult, and it's more difficult for parents than it is for babies. So I would start off saying, watch your baby for cues. So just because now they're in your home 24 hours a day, you can really watch for those cues. If they are reliable and they're, in other words, they're rousing that you can hear them, then follow those cues right away. If they are not, if they're very silent or subtle, or you just don't notice them at all, then you stay on a semi-demand, so that maybe after about 3 hours, you just kind of undress your baby saying, do you want to wake up now? And let them kind of arouse on their own. So don't just pick them up and say, let's feed, because it's been 3 hours. Let's see if they can arouse on their own. And then finally, I suggest that you take your, let's say you're taking 60 mils times 8, that's 480 mils per day. That is a reasonable goal for your baby to drink for some babies. And so I would suggest you start writing it down. And so then as your baby is feeding 40 mils here and 70 mils there, like different amounts, different time, you look over 24 hours and go, not bad. He's within 50 of that goal. That's good. So let's try again tomorrow. And so you just kind of look at your 24-hour goals rather than that one feed. And if 60 mils goes in, that's not the measure of success. The measure of success is over time. Does your baby accommodate it? Because you may find your baby is more hungry in the morning, more hungry in the evening, or all night, or all day. So every baby is different.
Karen, but for babies who are exclusive breastfeeding, not taking any bottles, how moms can, or parents can reassure the babies that are taking enough and gaining weight, especially this time where the appointments are not as often in person as they used to be?
Yes. So a couple options are looking at the normal things. Are they wet every diaper? Are they having regular bowel movements? Is your baby generally behaving comfortably? Is your baby fussy all the time? So we're looking for signs of dehydration or irritability or lethargy because your baby's not drinking enough. And then finally, there are locations that you can loan a scale or rent a scale, or maybe there's with COVID, you have to phone around and see, is there a place that you can actually get some follow-up? Like in the breastfeeding clinics are often really good at getting this ongoing support for families. So yes, it's really hard not to have that wait regularly, but maybe once a week might be sufficient for your families for that are exclusively breastfeeding.
Okay, we have a great question here from Nina. When home should the baby be woken up at night to feed if she isn't waking up on her own? This is such a good question. I think all parents need to know that. Is it safe to let the baby sleep through the night without feeding in the beginning?
Okay. First off, yay, your baby's sleeping longer at night. That's fantastic. So many times I hear families say the baby's sleeping well during the day and not at night, but that's a whole other question or another whole topic. So what I would suggest is, again, look at those 24-hour volumes. And so at 10 o'clock at night or 8 o'clock at night, you're going, yeah, he's kind of close to what the baby was supposed to be drinking. Then you're good. Say, let the baby sleep. And then you start again next day. So if your baby is, maybe if the weight gain is inadequate and your doctor or your nurse is concerned about weight gain or growth, maybe by late evening, you're kind of going, yeah, I better wake her up in the middle of the night for a feed because she's not really getting enough during the day. So it really depends on overall how your baby is doing growth wise and by just general their intake. So I really suggest doing an intake diary for a while so that you can feel confident that at 10 o'clock at night that when you put your head down on the pillow, you go, I'm just going to let her wake up by herself. And that is every parent's dream. So I only say wake up your baby at night if they're not gaining weight well and they're not achieving their target ranges, and the physician or nurse is concerned for your baby's weight and growth.
Absolutely. One more question here from Diane. As babies learn to suck their thumbs, how can I differentiate this action as a hunger sign or the baby discovering a new body part? Great question, Diane.
Yeah. Absolutely. And they love to put their hands in their mouth. And so, you're going to have to almost look for other cues, and kind of look at the time a little bit, and look at other cues, and just sometimes parents will just say, well, I offer it. And the baby took only 20 mils. That's all so he really wasn't hungry. He just kind of took a little bit. So you're going to have to experiment. Every baby is different, but yeah, absolutely. Sucking on those fingers and can be kind of confusing as they get older and can get their hands up in their mouth. So you're just going to have to experiment a little bit.
Absolutely. Karen, can you talk a little bit about your book? I'm sharing the cover of your book here with our audience because your book has so many great strategies and great information for families. We absolutely love the book.
Thank you. Tammy and I put our heart and soul into this book, and we tapped into a dozen families, moms and dads who have gone through the journey of taking your baby home from the NICU. We have their comments, just throughout the entire book, just to kind of make this book come alive. So it's a book that's meant to be practical, for families to have strategies right from a book, and not have to rush out to a healthcare provider. It has really been, parents are almost wishing they had it in the NICU, and we do recommend we weren't even going to include the NICU experience, but our family team said, no, you got to talk about, having your baby in the NICU. So we started there, and sometimes families will get our book after they've left the NICU and they think, oh, I wish I had it before. So I would just say, share the word. We've got really good positive results and feedback on Amazon. And so if you're happy with the book, we'd love to have your review online, because parents just love seeing another parent's viewpoint on our book.
Absolutely. Karen, thank you so much for joining us here today. Always great talking to you, and obviously share your book with our families, because I think this book is so great for everyone in the NICU.
Thank you. I'm happy to talk to you.
Thank you. And for all of you watching us from our YouTube channel or Facebook, thank you for joining us. I know we have an international audience today, so I'm very grateful to all of you who took the time to join our live sessions. We'll be back in just a few minutes with Dr. Takeshi Arimitsu from Japan, sharing chances and challenges of tiny babies. And I want to thank our sponsors, Midela, Water Wipes, and Prolacta Bioscience for their ongoing support. CPBF is a charitable organization, and 100% of all donations received this week will go to our support programs for families. To donate, please go to the CanadianPreemies.org. Stay tuned, as we'll be back in just a few minutes with Dr. Takeshi. Thank you so much. Hello, everyone. Welcome to the Preemie Health Talks. If this is your third session of today, welcome back. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, and GLANCE, the Global Alliance for Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For this Preemie Health Talks, we brought experts from all over the world and Canada, and we'll be diving into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practice to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. And I want to thank our sponsors, Medela Water Wipes and Prolacta Bioscience. Please use the comment area below your screen to ask and share your perspective and stories. And today we're going to talk about challenges and chances in marginally viable tiny babies. In 2019, a male infant born at 24 weeks of gestation with a birth weight of 268 grams was discharged from hospital. The case gained media attention all over the world, and many questions were raised. The complications of a marginally viable tiny infant is possible with minimal handling, family involvement, and breastfeeding beginning shortly after birth. Dr. Arimitsu hopes this presentation will provide valuable information to physicians, families, and people who are related to tiny babies. Dr. Takeshi Arimitsu is a neonatologist in the Department of Pediatrics at Keio University Hospital School of Medicine. He has extensive experience in caring for marginally viable small infants, including a girl weighing 265 grams at birth in 2007, the second smallest baby in the world at the time. He bases his medical treatment on being natural and warm-hearted, believing that less medical treatment and more pleasant experiences for the baby should be the main points of consideration. Dr. Arimitsu integrates all possible strengths in treatment, including the patient's family, staff, new medical devices, and the NICU environment to support infants and their future lives. He has authored textbooks on developmental care and peer-reviewed publications on non-invasive functional neuroimaging. He also established the Japanese Organization for NICU Families, the first nationwide parental network for preterm infants in Japan, and has been providing family support as its representative director. I have to pre-record Dr. Arimitsu's session because of our time difference. He's in Tokyo, many hours ahead of us here in Canada. But he told me that you can still send your questions and comments. I will share with him and he will provide answer to you. So here's our recording. Dr. Arimitsu, thank you so much for joining us here today. Such an honor to have you. I really appreciate your time. You're joining us from Tokyo. I know it's morning for you, so I really appreciate the time that you're taking to share your experience and knowledge with us.
Yeah, thank you for having me today, and give me time to talk to you.
Thank you. You can start sharing your screen. We're going to go through your presentation, and we have some questions at the end.
Okay.
Okay, here you go. Okay, you can go on a full slide now. Okay, and you're good to go.
Okay. Thank you for your I'm Takeshi Arimitsu from the Department of Pediatrics, Keio University School of Medicine. Today, I will talk about the challenges and chances in marginally viable tiny infants by describing my experience as an attending physician for the world's smallest baby boy at the time. Neonatal medicine has dramatically improved the treatment outcomes of low birth weight infants. Although the survival rate of infants weighing less than 1,000 grams is improving worldwide, a high mortality rate and the incidence of severe complications remain common for infants weighing less than 300 grams at birth, particularly in male infants. In recent years, there have been frequent discussions regarding the ethical and social issues involved in treating marginally viable tiny infants. Despite the challenges, reports of such infants surviving are increasing. However, lack of evidence and experience may make physicians reluctant to treat marginally viable tiny infants. Accumulating evidences will advance neonatal medicine and help to address many of the social and ethical issues surrounding their treatment. Progress of neonatal medicine will be achieved through sharing the same purpose with different global stakeholders, including infant families. In 2019, a preterm boy weighing only 268 grams at birth was discharged from Keio University Hospital in Japan. At that time, according to the University of Iowa's Tiniest Babies Registry, he was believed to be the tiniest boy in the world to have been successfully treated without experiencing serious complications. Today, I would like to review my experience as an attending physician by presenting the case of this 268-gram preterm boy. There are 4 important learning points from the successful discharge of this 268-gram boy. First, preterm infants with weights as low as 268 grams can be expected to survive without serious complications. Second, treatments, examinations, and procedures should be minimized. Third, the family should be involved as much as possible. And fourth, the desire to help babies and support their families is a universal one in the world. Of these, most importantly, we need to believe that preterm infants with birth weights as low as 268 grams can be expected to survive. Before 1960, survival of newborns weighing less than 1,000 grams was quite rare. But there is a report of a girl born at 283 grams in 1938 who survived and was discharged from the NICU. This fact certainly suggests that a 268-gram boy can survive. However, it does not mean that all newborns should be treated. The lighter the birth weight, the lower the survival rate and the higher the incidence of long-term sequelae. Careful consideration from various viewpoints, including culture, economy, geography, society, and ethics, is important before treatment is started. In the present case, the family requested treatment, and we were also prepared to providing the necessary medical care. So we started treatments. The next learning point is that treatments, examinations, and procedures should be minimized as much as possible. In other words, avoid unnecessary treatments, examinations, or procedures should be performed. Over-treatment could be fatal to the vulnerable infant's brain because any medical practices have risks such as side effects and complications. So reducing all these factors can prevent brain damage. With this in mind, I would like to review our initial treatment for the present case. His mother was 30 years old and preemie gravid. She had no past medical history and had become pregnant via natural insemination. At 23 weeks of gestation, she was referred to our hospital because of severe fetal growth restriction and was treated with antenatal steroids. The boy was delivered by emergency cesarean section because of interrupted umbilical cord blood flow. There was no umbilical cord coiling or amniotic fluid staining. A boy was intubated with a 2 mm endotracheal tube in OR and admitted to the NICU. The birth weight of the boy was 268 grams, and his Apgar score was 2 and 6. The umbilical artery pH was 7.28. An umbilical vein catheter and peripheral artery line were put in place. The boy's body temperature was 35.8, and his heart rate was 168. His respiratory rate is unknown because he was receiving high-frequency oscillation management. His blood pressure was 32/17, and his SpO2 was 96 with an FiO2 of 0.4. He showed a good general condition, good body movement, good skin color. There were almost no special notes regarding the blood test results, including blood gas. This slide shows the clinical course of the respiratory management. For the respiratory management, HFO was used because of the small lung volume. Caffeine was administered from day 0. Surfactant was administered on day 0 and day 2 because the FiO2 was required to be 0.3 or higher to maintain an SpO2 of 90 or higher. Regarding the circulatory management and sedation, the circulation was good and the fighting was not observed. Therefore, no inotropes or no sedation were administered to minimize treatment. PDA closed after indomethacin administration on day 1. The subsequent clinical course was smooth. We managed his respiratory condition with low MAP and low FiO2. The intubation period was 45 days. Steroids were administered prior to extubation. After extubation, the infant's respiratory condition remained stable with CPAP and high-flow nasal cannula. At the time of discharge, the infant did not need any respiratory support, including home oxygen. We also try to minimize procedures and care. Minimal handling promotes the stability of infants and reduces stress for them. Reducing stress caused by pain has been reported to improve the long-term prognosis. Tracheal suction was performed only when necessary and was not scheduled. Blood tests, such as heel sticks, were avoided as much as possible. This slide compares the number of procedures in the NICUs during the first week of life. Newborns admitted to the NICU can undergo as many as 5 heel sticks and 9 episodes of suctioning. In my case, the 268-gram boy underwent 5 heel sticks and 9 entracheal suctions per day at maximum, and as few as 1 time each during the first week of life. He was successfully treated with minimal handling. The third learning point is that the family should be involved as much as possible. In addition to minimal handling, we encouraged family involvement from the day of birth. Family involvement provides an essential supportive foundation in NICUs and is important for lifelong relationships among family members, facilitates breast milk feeding, reduces stress for both the infants and their families, and promotes the stability and development of the infants. In the present case, from the day of birth, the family began to talk to the boy and to hold him. Oral breast milk application was performed by the family from day 1. One of the most important factors in family involvement is enteral feeding with breast milk. Breast milk can reduce the risk of organ damage, including necrotizing enterocolitis, severe bacterial infection, and lung and brain damage. Breast milk can also enhance family-infant bonding. This video shows a breast milk application session performed by family members. You can see that the boy is reacting to the voice of the family members and the taste of the breast milk. Here, I show the clinical course of nutrition. He started the oral application of breast milk from day 1, increasing the amount of breast milk by 10 to 20 milliliters per kilogram per day. Fortified breast milk was used from day 20 when the infant's breast milk consumption reached 100 milliliters per kilogram per day. We maintained him on a breast milk diet for most of his hospital stay, adding medium-chain triglyceride oil from day 94 to 133 for calorie enrichment. One of the main reasons why the infant's nutritional management was so successful was that his mother provided him with breast milk from early in his life. Thanks in part to breast milk, the infant did not suffer from necrotizing enterocolitis, and we were able to increase enteral feeding with little concern. Later, he was able to drink breast milk on his own, like other babies, and was discharged on February 28, 2019. At the time of discharge, his body weight was 30 to 38 grams. No serious complications occurred, including periventricular leukomalacia, hearing loss, blindness, or bone fractures, apart from retinopathy of prematurity requiring laser treatment. And home oxygen treatment was unnecessary. The boy's mother said, "I can only say how happy I am that he has grown this much." The fourth learning point is that the desire to help babies and support their families is a universal one in the world. Thanks to the support and cooperation of their family and hospital staff, a lively boy with a birth weight of 268 grams was successfully discharged from our hospital. The discharge of this boy was also supported by the development of medicines and medical devices. Successful treatments can be achieved with the advancement in medical technology, including incubator and tracheal tube, ventilators, catheters, vaccines, medications, and so on. It is important to collaborate with different professionals to help and support their infants and their families. After this 268-gram boy was discharged from our hospital, I was interviewed about clinical outcomes of Japan and my experience by people from around the world, including neonatologists, politicians, and business people, families of preterm babies, and global media outlets, including the BBC and CNN. I also became a committee member of the European Foundation for the Care of Newborn Infants, EFCNI. EFCNI is the first pan-European organization and network to represent the interests of preterm and newborn infants and their families. Through my interactions with professionals from around the world, I became convinced that the desire to help babies and support their families is a universal one. I have started to collaborate with different stakeholders around the world to improve the future of their infants and to support their families. This is a picture of another lady who was born at a hospital 20 years ago and weighed 289 grams at birth. She celebrated her 20th birthday in June of 2019. She is currently employed and is an active member of society. Although each person's backgrounds, positions, roles, and values differ, I would like to see a society in which people respect, consider, and support each other. Our warm-heartedness nurtures warm human relationships and leads to a warm society. I hope to unite babies, families, healthcare professionals, businesses, government, and society around the world together with the same purpose. This summarizes today's story. The clinical course of the 268-gram boy presented today is described in detail in this article. I hope that this case report will aid in the progress of neonatal medicine and help to address many of the social and ethical issues surrounding the care of infants. Thank you for listening.
Dr. Arimitsu, thank you so much for sharing your experience with this case. Obviously, this case became well-known all over the world. But I think my first question to you is, 2 years later, how is the baby doing now? You mentioned he had ROP, he had laser treatment. Is there any other developmental delays at this point? Anything that you can share with us?
Okay. So, So the baby introduced today is gradually growing and developing in his own way. And so far, there is no obvious visual impairment. And I think there is a wide range of growth and development in very preterm babies. Some babies grow and develop very quickly, while others do more slowly. What is important is that society as a whole, including medical professionals, should stay close to the families after discharge from the hospital and provide the necessary medical care and social support to the children and families at the proper points. The realization of such a society cannot be done by any one person. Each of us has different values and laws, but we need to support and respect for each other.
Absolutely, and I think the support varies from country to country. I know in Canada varies from province to province. How long do you do follow up with the premature babies in Japan?
We follow up them at the elementary school, age 7 or 8 years old.
Wow.
At least. It's recommended in Japan.
And all the supports are available for families, from like medical therapies and help for school as well?
Pardon?
Are the supports available for families in terms of therapies, support for the school, so the schools are aware when the babies are premature and they enter the school, so they can provide extra support if needed?
Yes, there are systems to support the preterm infants for medical care, for special medical care and special education. But it is one of the major issues need to be improved in Japan.
Well, I think all over the world, for sure. In Canada, we have a lot of work to do, especially with the education system. But that is incredible that you follow up the babies much longer than any other country. As far as I know, that is incredible. I think we have a lot to learn from you. But Dr. Arimitsu, a question for you, because this case, when the baby was discharged, as you mentioned, it was all over the media. A lot of conversations, how far science can go. And we still know physicians is still, there is some, they hesitate to care for those babies when they are less than 300 grams. So when you look back into your own experience, what are your thoughts around it?
Okay, so in the present case, the baby I introduced today was discharged from our hospital without serious complications, and the bonding between the baby and the family was firmly formed. In recent years, there have been growing number of reports of tiny infants being discharged from the hospital. So with the development of neonatal medicine, more tiny infants can be saved and the risk of complications can be reduced. However, this case does not suggest that all newborns should be treated. So before treating tiny infants, we need to talk with the family and consider medical, cultural, social, and ethical perspectives.
Absolutely. So that was my next question to you. If the parents were involved in the decision making.
Okay. So the parents of the boy were involved in the decision making process. So before the birth, the neonatologist talked to the parents about the clinical outcomes in Japan and at the hospital. So the medical care given to the baby and possible complications after the birth. Their family decided to have a cesarean section and treat the baby. After the birth, we explained the situation to the parents on a daily basis, and they participated in the decision-making process.
This is incredible. It's such a very important conversation. It's a very difficult conversation to have with parents, right? The moment that you're in preterm labor, or you have to deliver the baby in an emergency section, that conversation, I think, stays with the parents for the rest of our lives, because the prognosis, if it's extremely preterm or a very tiny baby, it's very difficult. And I'm glad to hear the parents are present in those decisions. So, but obviously, as we had talked before, the gestation age has a huge influence whether to proceed with care for the tiny babies. So let's talk about the gestational age, because does it change even with those the minimal handling or having the parental engagement and the oral immunotherapy for the babies based on the gestation age as well? What have you seen?
Okay, so the clinical outcomes of treatment depend on the number of gestational age. So the number of gestational weeks is one of the factors that have the greatest impact on the outcome of treatment for newborns. So if this newborn had been born at 22 weeks, we would have been more delicate. And if he had been born at a larger number of weeks, we might have been a little less nervous. However, no matter what the number of gestational weeks the newborn is born, I believe that minimal handling and breast milk are always useful to reduce stress and complications for newborns and to establish the foundation for family attachment.
Okay, so you talk about obviously breast milk, and we are always promoting breast milk because we know how much better babies do. But we also mentioned that you fortified for this baby. So how many weeks when you start fortifying, and do you think that contributed to the successful discharge of this baby?
Yes. So nutritional management is one of the important factor of neonatal treatment for tiny infants. So in addition to the benefits of breast milk, we need to use the fortified milk to enrich the calorie. So we usually use fortified milk when the infants become 200 grams, but that depends on the infants. We modified our protocol according to their growth charts or the medical conditions, including complications.
Okay, so we saw from different studies that Japan has a 90% survival rate of the tiny babies. So is always the same approach with all the tiny babies in all the hospitals in Japan, or this is particular in your unit?
Yes, so the content and the management which I presented today is partly our special management. So even in Japan, there's a wide variety of treatment protocol for tiny infants, and so we need to exchange our information and discuss what is the best choices for tiny infants.
Okay, so you also obviously we talk a lot about parental engagement, and also this varies from country to country, unit to unit. Even sometimes here in Canada, a hospital across the street from each other have different ways to engage parents. So is it common practice in your unit with all parents to have to be engaged in the care of their babies, or this is a more is a practice for more tiny babies, or this is the way you practice there?
So in a hospital, we try to increase family involvement as much as possible from the early postnatal period. So the specific way of interaction depends on the newborns and their family. So for tiny infants like the boy in this case, we do holding, talk to them, and early administration of breast milk. So in order for anxious families to interact with their infants in NICU with comfort, it is necessary to create a relaxed environment in the NICU for the family. So for this purpose, partitions and reclining chairs may be useful. However, the most important thing is our thoughtfulness to prepare the NICU for families to spend time together. And as you and some each hospital has its rules for family involvement, but I believe we need to increase parental involvement more.
So during this time with the pandemic, we know from units around the world, there are so many restrictions for parents to come and stay with the babies and to still be seen as an essential caregiver, but rather we've been seen as visitors in many places now. How is the situation in your unit? Are parents still coming and involved as they were before, or there's more restrictions as well?
So basically a hospital does not allow family to visit the patients admitted to a hospital. But for preterm babies admitted in NICU, so we try to increase family involvement and allow families to visit our unit to facilitate the family bonding for the development of the infants and in order to support the mental health of parents.
Are both parents allowed to come in at this moment, or will you have the policy of one at a time, or how is the situation there?
So now we are trying to expand the criteria to meet the very preterm infants. So we need to discuss for each case.
Mm-hmm. Okay, Dr. Arimitsu, any final thoughts, any final messages to physicians that are watching us here today that perhaps a little bit on the fence of saving such a tiny babies? I want to leave them with a message today.
Yeah, so thank you. So it's there has a very there's a discussion if we need to treat those tiny infants, but we need to accumulate the evidences for those infants, and we need to discuss about that with families. How to say? So when we each time when we think of before we start treatment.
Absolutely. Dr. Arimitsu, thank you so much for joining us here today. It was such a pleasure talking to you and learn from you and your experience in Japan. So thank you so much.
Thank you very much.
And for all of you watching us from YouTube or Facebook, thank you so much for joining us here today. If you missed a talk from today's sessions, you can watch the recordings on our YouTube channel and in a week or so on our website. And I'm going to share our website right here. And I want to thank our sponsors, Medela Water Wipes and Prolacta Bioscience for their ongoing support. CPBF is a registered organization, and 100% of all donations received this week will go to our support programs for families. To donate, please go to CanadianPreemies.org. Together can create a brighter future to all premature babies and their families. And tomorrow we'll be back on the second day of our Preemie Health Talks with Dr. Sharon Unger from Mount Sinai Hospital. She's going to talk about the human milk and COVID-19, implications for the NICU and milk bank. Also, the lactation consultant team from the Hospital for Sick Children will talk about supporting breastfeeding during the pandemic. So I will see you tomorrow. Thank you so much for joining us here today, and stay well.